Good morning, ladies and gentlemen. A very warm welcome to every one of you on this beautiful Saturday morning. The weather is looking great, and we're glad you can join us online today to the Singapore Cancer Society Breast Cancer Webinar 2022. My name is Ivy Lim, your host for this morning. Before we begin, I would just like to see, in the chat box, how many of you are actually returning to our webinars and how many of you are our new friends. So if you are new friends, press 1. If you are someone returning to our webinar, you have joined us in other webinars, press 0. So we have to see, how many of you are old friends that we've been seeing, and some of them are how many of you are new. All right. Thank you very much. And I think online, let's take a look how many we have today. We have 215, 216 coming up. Oh, great. Oh, we see a lot of new friends actually. And hopefully we will have some others who have been with us before. Thank you for participating. I know it's Saturday. There's a lot of things we can do outside the house. And I promise you, this is a very good session. We have a very great panel here today. We would like to thank our sponsors, MSD and AstraZeneca, and partners, Breast Cancer Foundation, National University Cancer Institute of Singapore, Screen for Life, Sing Health, Tan Tock Seng Hospital for their support to make this breast cancer webinar 2022 possible. Before we begin, a quick introduction about Singapore Cancer Society. Singapore Cancer Society is a community-based voluntary welfare organization with a mission to minimize cancer and maximize lives through its programs. Some of the programs include public education, screening, patient care services to needy patients, and hospice home care, financial assistance such as cancer treatment subsidies and rehabilitation support programs. This has benefited many people, and I personally have been a volunteer with the Singapore Cancer Society since 2008. Today's webinar will share with you all about breast cancer and what you can do to detect it earlier. We will end the session with Q&A. If you have any questions that you would like answered, remember to submit your questions by clicking the center icon, the Q&A box at the bottom, if you're on Zoom, or send your questions into the comment box on Facebook. This is actually streamed live on Facebook, and we will try to answer as many questions as possible as we can. And in the event we are unable to answer all of them today, we will pick the top 50 most commonly asked questions and post it on No Cancer to Beat Cancer microsite. Where can you find this microsite? You can find it in the Singapore Cancer Society website at www.singaporecancersociety.org.sg. If you wish to re-watch the webinar again, or you wanted to know, what was seen, you want to take a look at it again, you want to share with your friends, which I totally encourage you to do that, you can actually check out the Singapore Cancer Society Facebook page again. Again, this is actually streaming live on Singapore Cancer Society Facebook page. So if you have quick fingers, WhatsApp your friends, join me. It's a Zoom session. All right. Next, we're going to welcome our first speaker. Our first speaker is Professor Patrick Chan. He's the Senior Consultant and the Director of the Breast Cancer from the Tan Tock Seng Hospital. He'll be sharing with us on early signs, symptoms, and screening for breast cancer. And over to you, Dr. Chan.
Hello, good morning, and thanks for joining us for this webinar on breast cancer. I'm Dr. Chan. I'm a breast surgeon by training. And today I want to share how we can keep breast cancer in check I'll look at two strategies. But first, we all know that breast cancer is the commonest cancer in women today, and over 2,200 new cases of cancer is detected every year in Singapore. It is estimated roughly about 1 in 11 women in Singapore will get breast cancer in her lifetime. Now, even though majority of patients come in with early breast cancer, but we are more concerned about is the almost a quarter of them that comes in at stage 3 and 4. And really to bring down breast cancer death, it is this group of patients that we need to identify earlier. And so the first strategy that I'm going to look at is to look at the risk factors for breast cancer and how we can try to mitigate them. The first thing is I want to talk about is non-modifiable breast cancer. And these are risk factors that, well, we have no control over, but still we want to know a little bit about it. And the first is, of course, age. So breast cancer increases with age. So it's not true that some people think that breast cancer do not arise after one menopause or even the elderly. That's not true. However, in recent years, we also see a trend that more and more breast cancer patients are diagnosed before the age of 50. Next, gender. We all know, of course, that breast cancer is a predominantly a woman's disease, but for every 100 women diagnosed with breast cancer, we will find one male breast cancer. So, if a man has some breast symptom, please seek medical attention as well. Thirdly, breast cancer risk increases when there's a strong family history of especially breast and ovarian cancer, and if the family members develop these cancers at a very young age. The next speaker will dwell a little bit more into family history and gene testing, and so I will leave it to her to tell you all more about it. It's increasing evidence that breast density, so the denser the breast, the higher the risk of breast cancer. So that's something to look out for. And finally, if there are a previous biopsy with a diagnosis of atypical hyperplasia, then the patient has a slightly increased risk of breast cancer 8 to 10-fold. Now, we know that breast cancer has a causative effect with estrogen. And so patients who have early menarche, late menopause, they are exposed to longer periods of estrogen, and so they have a slightly increased risk of breast cancer. However, more importantly, is the usage of oral contraceptive pills and especially hormone replacement therapy. We know that patients who take hormone replacement therapy has a higher risk of breast cancer, and thus it is very important that when a lady is thinking about starting HRT, there must be strong reasons to do it and perhaps not to take it for more than 3 to 4 years. On the other hand, pregnancy reduces our risk of breast cancer, especially if the pregnancy is at a young age. So below 30, 25, right, it is very protective. Also, breastfeeding reduces our risk of breast cancer. It's estimated that the relative risk of breast cancer can be reduced to about 1.5% for every 12 months of breastfeeding. Now, let us then look at some lifestyle changes that we can do to reduce our risk. And the first is to be physically active. All right, so the recommendation is to have at least 30 minutes of moderately strenuous activities or exercise per day, and do that 5 times a week. Okay, so the next one is, of course, avoid alcohol consumption. But if you really want to have that drink, limit it to not more than 1 unit of alcohol per day and no more than 5 units per week. And finally, maintain a healthy weight. So it is especially important in a postmenopausal setting where if the patient has postmenopausal weight gain and is obese, there is a 2 to 5-fold risk of breast cancer risk. Let's now turn our attention to dietary modifications. Right. The first is to limit red meat such as beef, mutton, and pork, right? And as well as processed food. So limiting red meat is not just good for a reduction of breast cancer, but other cancers such as colorectal cancer, and also other conditions in our body such as strokes and heart attacks. So really it's something that we can look at. Instead then, our diet should have generous servings of whole grains, vegetables, and fruits, right? And finally, cut down on our sugary drinks. Okay, so the bubble tea, reduce sugar, maybe kopi O, for example. Okay, so many patients ask me, is soy safe for breast cancer patients? And fortunately, there's been many studies that's been done, and they have found. And these studies not only a study on healthy individuals, but also on breast cancer survivors. And they have found that there is soy intake, both for the healthy individuals as well as breast cancer survivors, have no negative impact on breast cancer. In fact, some studies, like the last paper shown here, actually mentioned that there might be actually some protective effect of soy on the breast. Now, The second strategy that I'm going to talk about is how to recognize breast cancer symptom and also breast screening. Okay, so breast cancer symptom, the commonest is a lump in the breast. All right, regardless of whether it's painful or painless, that would be a red flag. The other less common symptoms would include sudden change in shape of the breast or nipple, a sudden increase in the breast size, as well as bloody nipple discharge. Any lady who have these symptoms should seek early medical attention. Now, so why breast screening? And so here, I'll just quickly, briefly look at how breast cancer developed. So if we look at the center picture, you can see that breast cancer develops from the lining of the milk duct. And when the breast cancer cells are confined within the milk duct, this is called ductal carcinoma in situ, or stage 0 breast cancer. And here you can see that treatment outcomes for patients with stage 0 breast cancer, the one on the left, approaches almost 100%. So this is something that, and you can see that as the presentation of the stage of cancer rises from 1 to 4, not only is the treatment more difficult, but also the treatment success is less. Thus, the main aim of breast screening is to detect breast cancer at the early stage so that we can get better outcome. Certainly, if the patient has stage 0 breast cancer or very early stage 1 breast cancer, they may also avoid chemotherapy. And lastly, ladies with very small cancers may avoid the whole breast removed during surgery. And here you can see that even though our breast cancer incidence in Singapore is rising over the years, but the death rate, which is represented by the dotted pink line, remains roughly flat. And this is mainly due to better treatment options, but certainly it also impacts when patients come forward for breast screening. So we recommend, firstly, that every lady should do breast self-examination. Usually we would suggest that they do it 5 to 7 days after their menstruation have stopped for premenopausal lady, and for postmenopausal lady to do it once a month. Okay. So the symptoms that one look for is, of course, those symptoms that I've shared before. However, it is very difficult to detect stage 0 breast cancer and very small cancers with breast self-examination alone. And so we need to resort to an X-ray of the breast or mammography. Now, mammography is accurate. It can detect correctly almost more than 90% of breast cancers. It is safe. The radiation risk, the radiation dosage of a mammogram is maybe just slightly more than 10% of the background radiation that we receive annually. And we are also having newer techniques of a mammogram, such as contrast, enhanced mammogram, digital breast tomography, which will increase our detection rate. So in Singapore, we have a national breast screening program called Breast Screen Singapore, and this is a heavily subsidized mammogram that you can do in the polyclinics and the mammo bus. All right, for ladies who are 40 and above, you are eligible to go for this screening. And so usually for ladies 40 to 49, we would suggest annual, and for ladies who are 50 and above, once every 2 years. And so in summary, 2 strategies to keep breast cancer in check. Firstly, reduction of breast cancer risk by regular exercise, avoid postmenopausal weight gain, avoid red meat and processed food, limit our sugary drinks, and of course, avoid or limit alcohol intake. One should practice a regular breast self-examination, recognize the symptoms, and of course, seek medical attention if there's any. And finally, when you are eligible for screening mammogram, please step forward, because that will not only save breasts, but it may save lives. Thank you very much for your attention.
Thank you. Thank you, Dr. Chan. Thank you so much, being our first speaker and sharing the early signs, symptoms, and screening for breast cancer. And our next speaker, we are welcoming Dr. Joanne Yao, our senior consultant from Division of Medical Oncology at National Cancer Center, Singapore. She will be answering the questions on when is genetic testing needed for you and your family. Over to you, Dr. Joanne.
Very much, Ivy. And again, I echo everyone's warm welcome this morning to joining us on this webinar. Also, thank you to Singapore Cancer Society. I must say, Singapore Cancer Society has been a very big supporter of early detection, and we're very grateful that we're all here today to share. So I'm going to talk a little bit about genetic testing. It's used very broadly, the term. So patients sometimes get confused about when it's needed and when is it needed for me as the patient and when is it needed for my family. So there's slightly different questions there. So I'm going to start again by reiterating that cancer is a big public health problem, not just in Singapore, but also globally. But when we say things like cancer is the leading cause of death, it's very abstract. In more absolute terms, 40 people are diagnosed with cancer every day, and about 15 people die from cancer every day, and 1 in 4 may develop cancer in their lifetime. I'm trained as a medical oncologist, meaning that I typically usually treat patients in stage 3, stage 4 cancers, but it's very clear to me as a physician, as a citizen, as even just a member of the public, that the war against cancer cannot be won in treatment, but more won in terms of early detection and prevention. And so it's very, very important, therefore, where every Breast Cancer Awareness Month, we highlight the need for screening and early detection. And this number will only increase because over the next decade, we are going to see an aging population. And as Dr. Chan has already highlighted, a lot of the lifestyle risk factors are also going to increase in general unless we take active steps to reduce them. And the number may go up to 1 in 3 Singaporeans who develop cancer, whether it's breast or colorectal cancers by 2030. So we really want people to start acting today and not waiting till this reality comes. How do we actually stop this tsunami? We stop this tsunami by doing 2 things. One is we want to stop people from getting stage 3 and stage 4 cancers. The print is a bit too small, I apologize, but the highlight of it is that for colorectal cancer, about 50% are diagnosed in stage 3, stage 4 in Singapore. In breast cancer, as Dr. Chan just shared, about more than a quarter is in stage 3, stage 4. So this number is not good enough, and we want to do better here. The other way to stop this tsunami is to stop thinking that cancers are caused by bad luck. I've been in practice for more than 20 years now, and it's very common that patients will come in and say, "Sway lah, this is something that happened to me." But that's not true. Okay, there's a lot that can be done. Some are modifiable, like your lifestyle. Even non-modifiable risk factors such as your family history or the genetic factors, it is still important information that can modify how we manage you and therefore mitigate the risk that brings around. So I don't really believe that there's nothing we can do to stop cancers. There are a lot of things we can do to stop cancers. So I think changing this mindset is an important one, especially in the local population and actually in our region. It's a very common refrain that I hear from patients. So as was highlighted, for the general population, this is from the Health Promotion Board. We have very, very good general population health screening that's put out by HPB, especially the Screen for Life program and others, where it's very age-based. When you're of a certain age, you need to go for your certain screening. So for age 50, you need to go for colorectal cancer, breast cancer, age 40, cervical cancer screening starts, age 25, even the cervical cancer. So by age band, as Dr. Chan has shared, that's when you're one of the risk factors for cancer starts to arise, you go for your general population screening. However, not everybody goes for this, right? And these are some of the most commonly cited reasons why patients do not go for health screening. It's not necessary because I'm healthy. There's no time to go for health screening, or it's too expensive. I will say that the last bullet point, I think Singaporeans cannot really say that these days because really they're very, very good programs. If you're not familiar, please just speak to your GP or your polyclinic doctor or anyone of us to find out about what's available for you because there are very, very heavily subsidized screening programs these days available. The other thing about age-based screening is that it doesn't take into account so much the individual risks. So I like to show this slide. Dr. Chan's really highlighted to you that there are lifestyle exposures that can be increase your risk, but that can also be protective. So those are the exposure risks, right? There's also genetic risks that can actually put you at higher risk. There are also genetic factors that can protect you. We don't understand as much the genetic factors that protect you, but we certainly understand about the genetic factors that increase your risk. So I'm going to speak a little bit about that now. So there is a field of medicine called genomic medicine. And what is genomic medicine? It is actually a medical discipline that uses genomic information about an individual to understand the health risks, to help stratify disease risk, and to guide clinical care, and to actually really provide a continuum of care to keep patients well, to prevent them from actually getting ill. And one of the things that we look for when we are thinking about who might need genetic testing, we use some of the what we call clinical red flags. So if you had your breast cancer very early, Dr. Chan mentioned before 35, before 40, these are the age ranges that we would use as someone who's a young age. If there's multiple generations affected in your family, if there is a specific patterns of cancer in the family, meaning individuals with breast, ovarian cancer, or even other clustering of cancers, please do reach out to your GPs, your polyclinic, or any one of us to discuss that. If an individual has more than one cancer in that same individual, that's also a risk factor. For example, bilateral breast cancers, that is a risk factor for genetics, and that's someone that we would like to make sure that it's not due to something genetic and that can be therefore managed differently. Certain pathology, cancer pathology types, we think about it a bit more, but in the breast context, that is not as helpful. But in some of the other cancers, we sometimes look at what kind of cancers it is as well. Breast cancer, as I mentioned, is got a strong heritable component. The main genes that's causing this is BRCA1 and BRCA2. These are just genes that are named after the families where they were first identified. There's some other gene changes. When we say something is autosomal dominant, rarely de novo, it's a medical jargon for saying it runs in families. We seldom see it in families where there's no family history. So the family history is a very big component, okay, of this. Now, why is understanding about hereditary breast and ovarian cancer syndrome important? I put up this slide here. Maybe I'll orientate you all first. The bottom horizontal line is age. So from 20 years old to 40 years old to 60 to 80 years old. This is what's called a lifetime risk curve. And this is what we use to decide at what ages people need to start mammogram. So you see the gray line, which is the lowest line on this, is the population risk, which is why you can see the breast cancer risk starts to arise after 40, and it keeps increasing above 80. So this is why from 40 to 49, you can start going for your breast screen Singapore, and age 50, that's when everybody should be going for their breast screen Singapore. So that's how the justification came. But you can see that the colored lines, right? BRCA1, BRCA2, PALB2, the blue, the purple, and the green lines, it's much higher than the general population. And the other thing to note is that this line actually starts a lot earlier than the age 50. That is the general population recommendation for mammogram. So what this means is that if you actually had the genetic fault that actually arises in these genes, that's in the colored lines, starting at age 50, we might miss as much as 1/3 of the individuals with these risks for breast cancer. So we do really need to understand this so that we can start managing this group of patients differently. So the other question that I'm always asked by patients as well as policymakers is actually, how common is this? Is this something that we read about only in the Western literature? How common is this? Is it even something we need to worry about in the Singapore context? And I will say up till last week, I probably cannot share any data with you, but we just completed a very large study, and I'm going to just share very quickly. The paper just got accepted. It's not even out yet, but that essentially we looked at 10,000 Singaporeans across general population, which is involving Chinese, Indians, and Malays. And as a collaborative group across the island, we looked at this, and what we found is that 1 in 150 Singaporeans carry the gene fault that is the ones that I talked about, BRCA1, BRCA2, and PALB2. That is quite a high number, okay? And what this means is that our breast screening guidelines may be so-called inverted commas wrong for at least 1 in 150 individuals who may need to start actually earlier than this. So this is one of the reasons why we want to highlight this, so that individuals with a strong family history, with young breast cancer, with male breast cancer, with bilateral breast cancer will come forward, and we can try and identify this and prevent this in the family members, okay? Recently, we all know about Angelina Jolie. Recently, HBOC has a new champion. This is Chris Evert. Chris Evert has also a BRCA1 mutation in the family. Her sister had ovarian cancer, and because of the sister's diagnosis, she went and get tested. And because she went to get tested, she went to have her ovaries removed because she was postmenopausal, and she was found at a very early stage ovarian cancer. So hence preventing a very tragic outcome for herself. And Chris Evert, if for those of you who don't know, is a tennis champion and a role model for many. So HBOC, for example, there's compared to the general population, the breast cancer risk is in red is much higher than the gray, which is the general population risk. So we really shouldn't be managing the patients similarly. You now familiar with the lifetime risk curves? Okay, so in black, these are the lifetime risk curves of patients with BRCA1 carriers. In black is on the right side is for the BRCA2 carriers, and the red is the ovarian cancer risk. Okay, so we can use data like this to help manage patients and know when to intervene. When should the patient be going for, let's say, for example, preventative surgery to remove ovaries? For BRCA2 carriers, we can start after menopause at age 50 because, as you can see, the curve on the red on the right is rises slower. For BRCA1, we have to discuss because at age 50, 11% of them would have already developed ovarian cancer by then. So this is helpful for us to therefore make this kind of discussions. So what is genetic testing and what to expect? So firstly, the patients will be referred usually by their clinician, their polyclinic doctor, their family doctor, or their surgeons or their oncologists. And they come for a consult where we go through a lot of this with them because patients need to understand what it means. Then they're consented, the samples are collected, and then results are then given to them. I also get asked by policymakers, does knowing your genetic risk make a difference? So I can share with you that we did a small study where we looked at the first 2 years where we were doing this. And what we showed was that the high-risk group, the patients with the genetic changes, 80% of them complied with their surveillance from then onwards. And 80% of them actually were compliant with the recommendation. So I do think that knowing your risk makes a difference. The other thing to sort of say is that doesn't mean that if you have a genetic change, you will have a worse outcome than others. If you're actually being monitored and being managed, your survival is similar to a non-BRCA1 or BRCA2 carrier. So it's very, very important that knowledge is important. Okay, so what will the doctor do differently for you if you had a genetic risk of breast cancer? Depending on the gene that's involved, it might involve increased surveillance. It might increase the recommendation for surgery for the ovarian cancer. And if you are needing metastatic treatment or stage 4 treatment, it may help guide the treatment. Okay, for the family members, each of your first degree family members have a 50-50 chance of sharing the same genetic fault, and in which case we want to know about that so that we can allow us to deliver appropriate care earlier. Okay. So the take-home messages are, it's important to know that you can take action. It's important to be your own advocate and know when you need what screening. Whether you have a gene fault or not, you should just know what is the recommendation for you in terms of when you need to have screening. There's a lot of research in this area, which is moving very fast. Keep updated together with your doctors. Keep in touch with your team, and also, as you can see here, we have a panel of doctors here. It's know your team of doctors that's looking after you. It's not often just only one person that you need to see, but more than one, okay? The other thing is that I firmly believe knowledge plus action is power. You've already heard that you should eat healthy, be active, and do all of that. There's a lot of hope, there's a lot of support, and there is also a part of the research that's ongoing that you can be part of it. And again, if you're interested in this, you can reach out to us as well. This is an example of this. We have a support group and patient conference called Living with BRCA. It's happening next week. For those of you who know families with BRCA1 or BRCA2 mutations, please do join us for this, which is happening next week as well. I'm part of a big team. I have a lot of people to thank, and in the interest of time, I won't. But we'll look forward to answering your questions. Thank you.
Thank you, Dr. Joanne. Thank you so much for sharing, on the genetic factor. And next, we are going to welcome our Dr. Jessie Hu. She's a senior consultant from the Division of Surgical Oncology at the National University Cancer Institute of Singapore. She will touch on how we can win the fight against breast cancer by sharing the new developments, surgical treatment options, and common concerns during reconstructions. Over to you, Dr. Jessie.
Thank you, Ivy. So a very good morning to everybody. So I'm going to share about how to win the fight if you have diagnosed with cancer, mainly about the surgical options that's available and common concerns that patients have. So there's nothing to disclose, but there's quite a fair bit of photos that we can see. Brief summary of my talk, we're going to talk about the anatomy of the breast, what's the principle of breast surgery and how it has evolved over the years, and what's the current surgical options available and what are the concerns that patients have. So as we know, the breast cancer, as Dr. Patrick has touched on, developed from milk ducts and milk lobules within the breast itself. And the principles of breast cancer surgery is to remove the cancer itself to achieve local regional control, which means removing the cancer in the breast and the lymph nodes in the armpit as well, and to maintain aesthetics in terms of the choice of surgery that's available, be it conservation or mastectomy with reconstruction. So how it has evolved over the years? Well, if we know about the history of breast cancer surgery, in the 1882, many years ago, Horsted actually described mastectomy as a removal of the breast tissue and the tissue in the axilla, which is the armpit, and the muscle underlying the breast itself. So this results in, you can see very obvious deformity in the breast, in the patient's breast, where there's only left with the ribs and the rib cage muscles. So this has stayed the same over the 100 years until the change in terms of early screening and picking up early cancers, where we have moved on to where we can have breast conservation surgery, which involves a lumpectomy, which is removal of the cancer itself, and the rim of surrounding normal tissue to maintain the aesthetics of the breast. So the first polling question I have is mastectomy or whole breast removal better than lumpectomy? Yes, no, or depends.
You're encouraged to participate in this poll. Just click on your screen, then you have your answers. Thank you.
So yes, so a lot of people choose depends. Some say yes and some say no. So the real answer is it depends. It really depends on the stage of the disease and the patients as well. So when we talk about mastectomy versus breast conserving surgery, there's many trials that have been available, as it's proved that it has equal outcome in terms of overall survival and recurrence risk, and with better cosmetic outcome. So in the many landmark trials, that has proved that it's been equivalent in terms of whether you choose a lumpectomy with radiotherapy or mastectomy, and there's no change in the overall survival or recurrence risk. So in summary, we have mastectomy, where we remove all the whole breast. At the bottom part of the picture, you can show that there's a skin-sparing mastectomy, where we remove the breast tissue, but we leave the overlying skin and the nipple as well, and we reconstruct the breast. Versus a breast conserving surgery, where lumpectomy is performed, but it always comes with radiotherapy, and the outcome is the same for most patients. So what are the available surgical options for breast conservation? As you can see, there's many options available, and I'll touch on it briefly. For lumpectomy, as we can see, is removal of the breast tissue cancer, and mastectomy is removal of the breast cancer. So in the recent years, we have what we call oncoplastic surgery, which is a combination of onco means removal of cancer, plastic means using surgical techniques to reconstruct the breast to achieve an acceptable cosmetic outcome. So the classification of oncoplastic surgery depending on the difficulty of the surgical skills involved and the area that we need to remove. And why does it matter? Because size matters in terms of tumor size. That means the earlier you pick up the cancer, the less we need to remove. And of course, tumor size is always in relation to breast size. So the first level 1 oncoplastic techniques will mean that we only need to remove about 20% of breast volume. There's no need to remove any skin. And as you can see from my picture here, the scars are well hidden, and normal people won't be able to tell that you have breast surgery at all. But when it comes to bigger area that needs to be removed, location matters. So from the orange peel, we want to avoid scars within the exposed part of the orange, because that is a V part of the neck where clothes can expose scars. So that's why scar placement is important as well. And other considerations that we think about when we look at the patients will be whether the breast is ptotic, That means whether you have saggy breast, the size of the breast in relation to the body size, and of course, comorbidities like whether you're a smoker, you have diabetes, which can affect wound healings. And when there's bigger area that needs to be removed, we think about level 2 oncoplastic techniques where we remove certain areas and we reconstruct the breast by rearranging the breast tissue to give it a so-called less ptotic or younger looking breast. So this we accept a little bit of asymmetry, but we can still achieve a certain volume and shape of the breast that's affected. And some patients will actually choose to do surgery on the other side to balance it out. But in Singapore, where our breast volume is a little bit smaller, we have other techniques, where what you call volume replacement techniques. That means we take tissue from other parts around the breast, not from the breast itself, to fill up the defect as happens. So we have what we call the perforated flaps, where we take tissue from the chest wall that's next to the breast to fill out the defect. As you can see from the mammogram itself, the overall volume and the shape of the breast is still maintained. There's no, there's proven to be safe in terms of cancer treatment. It does not increase operative time by a lot. And this is an example of a perforated flap. If the patient has not chosen a perforated flap, she will end up with a mastectomy because the volume removed is too big. And omental flap is where we take a tissue, the fat from the in the abdominal cavity itself, and bring it up to the breast to reconstruct the volume. And we also have implantables where the volume is not too big, and we can actually use certain implantables to replace a small area. For example, the fat that we take from liposuction, instead of throwing it away, we can re-inject into the breast to create the volume that's needed. So is it safe? The truth is, it is safe. We had a big Cochrane review, many meta-analysis of many studies to prove that oncoplastic breast conserving surgery is safe for patients with primary breast cancer. But of course, there are some issues in terms of fat necrosis and need for second operation if there's margins involved. But all this we can discuss with your breast surgeon. So what if you decided you do not want a lumpectomy? We have options of mastectomy, which is removal of the whole breast with reconstruction. So question, is breast reconstruction purely for aesthetics? So, well, I think most people are right. It's not purely for aesthetics. So in general, benefits of breast reconstruction is to create a breast mound so that the woman can look and feel normal again after treatment without permanent deformity. It helps wearing of clothes, fitting of a bra or swimsuit, and also psychologically, I think it's also important. The patient can feel better about her body. So breast reconstruction is medical reasons, Medisafe claimable, insurance claimable. So when do we do reconstruction? So there is immediate or delayed reconstruction. In recent years, we're moving more towards immediate reconstructions if we can, but of course the decision depends on many factors. It depends on the stage the cancer is found, the medical condition of the patients, and other additional therapies as needed. The main difference is in immediate reconstruction, we can try to keep the overlying skin and the nipple, and hence has a better cosmetic outcome. And there's no, and also it can be done in the same surgery at the same time. Disadvantages is it may be harder to detect any mastectomy skin problems. It has a longer recovery. It may potentially delay in adjuvant therapy. Hence, it's important to discuss with your doctor which is better for you. For patients who can't do immediate reconstruction, we can do a delayed reconstruction when the breast cancer treatment has been completed. But in this case, because we have already removed the overlying skin and the nipple, the reconstruction is only able to create the skin mound, and you can see the scar is a little bit different. So the options of reconstruction, you can see from this very busy slide, there's many options available. There's implants, and there's autologous, which means you're using tissue from your own body. For implant reconstruction, patient selection is important because we know that implants they are not ptotic, that means they do not sag. So we have to discuss with patient, there's a possibility of asymmetry in future. But of course, when we have patients who need bilateral implant reconstruction, it can create a very acceptable aesthetic outcome, like for instance, in this patient. For other patients who do not choose to have implant reconstruction, they can choose tissue from their own body. For example, latissimus dorsi flap, which is LD flap, where we take tissue from the back to create a breast mount itself. For example, for this patient, you end up with a scar in the back and a very acceptable breast mount on the left side. And you can see sometimes we do not have the very good, ideal outcome, but this is very acceptable with a little bit of deficiency in the upper part of the breast, but there's no limitation in shoulder movement at all. Some patients choose a delayed reconstruction, and this is one example of a delayed reconstruction. After a mastectomy, you have 2 lines on the chest, and subsequently when we reconstruct the breast, we actually have to take the skin from the back to recreate the skin mount. Other areas where we typically get tissue from are from the abdominal fat, which is what we call the tram fat from the reconstruction. It's kind of a little bit like a tummy tuck. Instead of removing the tissue and throwing away, we put the fat from the tummy into the breast itself. So for example, in this patient, you can see there's a scar at the lower part of the tummy, it's a tummy tuck, and she reconstructed the breast on the right side. And also sometimes we can spare the muscles. We don't have to take the muscle from the tummy at all. We just take the fat and to reconstruct the breast. And this will mean what we call a free flap. In certain patients where there are smaller breast volume, we do not need to take such a big area of tissue from the other body. We can do what we call primary fat grafting. That means we do a liposuction of fats from other parts of the body and we inject the fat into the breast mount itself. So for example, for this patient who is very, very slim and very active, so she wanted to keep her muscles intact because she's actually very active in her gym, and hence we only do a bit of liposuction to recreate a breast mount for her. What are the alternatives to mastectomy and whole breast reconstruction? So we have some patients who say, it's fine, I don't mind a mastectomy, I don't need to have a reconstruction, which is perfectly okay as well. So we have newer techniques where we have mastectomy without reconstructions. For such example, is Goldilocks mastectomy. This is for patients who have very ptotic breasts. So we remove the breast tissue, we keep the skin, we keep the nipple, and we reconstruct a new breast mount with the breast skin, excess skin of the breast itself, so that she has a smaller non-ptotic breast, which allows her to wear a bra. Also, we have what we call nipple sparing, skin sparing mastectomy without reconstruction, or what people do for patients who want to choose to convert from female to male. So we can apply that for breast cancer patients as well. So they can do a mastectomy, keeping the skin and the nipple, so end up with just a very flat chest, but with still the nipple intact. And of course, we have patients who say, it's fine, I want to go flat, I'll just have a mastectomy without reconstruction. So we have specialized swimwear which allow patients to go swimming and keep their active lifestyle. They also have prostheses which can wear in the bra, such that they can wear the same clothes without looking any different. And how do we choose what operations we want? So we have to personalize the surgical therapy. The considerations that we take into depends on the extent of disease, how much volume we need to remove in relation to the volume of breast there is there, and we will only offer conservation if we can achieve an acceptable cosmetic outcome. And of course, what's the disease subtype, and as Dr. Joanne has pointed out, genetics also play in a role. Ultimately, it's patient's choice. So have a discussion with your doctor to see what is the choice that you want to make. And we always work as a team with many besides myself as a surgeon, we have our breast care nurses, oncologists, and all that, and radiation oncologists and the genetic doctor to discuss what is the best solution for each patient. And I'd like to briefly talk about role of neoadjuvant therapy. So because with the change in cancer care, we know that certain cancers like the triple negative or the HER2 positive cancer respond very well to chemotherapy. So in such patients, we actually recommend giving chemotherapy before surgery to make the tumor smaller, to allow better cosmetic outcome, and also better outcome in terms of prognosis of the cancer treatment as well. And a little bit about axilla. Traditionally, we always do the axillary clearance where we remove all the lymph nodes in the armpit as part of cancer treatment. But we know that with the new therapies, systemic therapy available, we can potentially do less in the axilla, because the more we do, that's also always associated with complications such as lymphedema, arm swelling and such. So with the shift from axillary clearance to sentinel lymph node biopsy, where we actually take a little bit of lymph node to sample to see what is the prognosis of the disease and help us stage the disease as well. So, polling question. I am not eligible for breast conserving surgery or breast reconstruction because I'm too old, my breasts are too small, my breasts are too big, or none of the above. Yay! So none of the above. So the oldest patient I've done reconstruction is 78 years old. So there's no, age is not a limit. I think age is just a number. So I like to share that I think cancer is not death sentence. Cancer is not a stop sign. It is a speed bump. Okay, so the breast cancer survival rate is very good in the early stage. We achieve up to more than 90% survival. Hence, we need to think about what do we leave the patient with after treatment, and that's why I think there's many options in terms of oncoplastic techniques and new reconstruction techniques that we can consider. And when life gives you lemons, make lemonade. So I have patients who choose to upsize because they want to have bigger breasts and they have bilateral reconstruction. I have patients who want to downsize because they feel that they're having backaches from their breasts and they rather take the chance to do a symmetrization on the other side. And of course, we have patients who say, I'm fine with the breast size, keep it the same size. Hence, and also we have preventive mastectomy in patients, for example, in Angelina Jolie, she doesn't have breast cancer, she has the BRCA gene, but she decided to have a prophylactic mastectomy to reduce the risk of breast cancer. And you can see in this latest photo of her, 10 years after surgery, she's still wearing a gorgeous dress at the red carpet. So the take-home message is, I think oncoplastic surgery is a surgery that is considerate to what we leave the patients to live with for the rest of their life and should be an integral part of treatment for all patients with breast cancer. There's no one-size-fits-all. It's a personalized treatment and it's a choice that is made by the individual after discussion with your doctors. And also we need to share that a lot of times breast cancer survivors are able to wear bras and go on lingerie aids, for instance, in this case for Marks & Spencer and locally for another bra company, and live a fulfilling life. And hence, it's important to get screening early. This is our NCIS call for screening. And also we have many activities available right now, so please join us if you can. Thank you very much.
Thank you, Dr. Jessie. Thank you so much for sharing. It's always not easy, especially a lot of women feel that their breast is actually a signature of womanhood. And thank you for all the models, or rather the patients who have shared their pictures with us, to present a case that this is real and what can be done, versus using infographics. So we hope no one is offended with all this, and this is actually really for education purposes and awareness purposes. So before we move to the Q&A segment, let me welcome Madam Yu Poling, a breast cancer survivor with an inspiring life post-cancer. All right. So you can see, a very beautiful polling today. I love your glasses. I love the colors. It's so vibrant. And Poling, how are you today?
Good, good. I've been very well educated by the doctors here today.
That's great. That's great. I'm just wondering, did you attend any such talks before your diagnosis?
No. No, I didn't attend any. But I do read up about breast cancer and all that. So yes, I was a bit informed.
I see. Did you, sorry, I'm just going to be very personal about this. Did you do your yearly checks before your diagnosis?
Yes, I'm a
You did.
firm believer of mammogram. So I go for yearly checks ever since I was in the 40s. So I'm a firm believer.
So this was discovered during your regular mammogram session?
No, it wasn't. It was discovered only between the mammogram sessions. was just before I went for my mammogram. So
I
I did
see.
a self-check, and that's how I discovered that I had a lump. And then one thing led to another.
Yes, actually self-discovery or sometimes discovered by your partner is more often than not the case versus being picked up by the mammogram, you know. So how long has it been since you defeated breast cancer?
I was diagnosed in end of 2019. I spent the whole year of 2020 going through treatment. So it's been about less than 2 years since I'm cleared. 2 glorious years.
2 glorious years and a beautiful 2 years. And
Yep.
I'm sure it's not easy because, you know, if you're talking about that timing, it's actually at the height of COVID. And I'm sure your recovery journey is very unique. You know, how did you feel when you heard about it and it's at the peak of COVID, and then you think you're going to receive treatment? You know, what comes to your head immediately?
When I was first diagnosed, I mean, initially it was in shock. I did the crying, I did the pity party, why me, that kind of thing. But when that was over, I was just focused on getting well. So, and COVID struck at the right, I mean, at the right time, because everyone was out of the mask, and that helped. And it was also good because everything was indoor, the air was clean, so-called cleaner, because no one was outside, kind of thing. So that helped as well in the recovery.
I see. That's true. That's true. And I also heard from the information that I was given, not that they gave you a whole bio, that you are quite a career woman, you know. Could you share with us a little bit about your life before the diagnosis? You know, what kind of lifestyle did you have? Yeah.
Okay. Before my diagnosis, yes, I was a career woman. I was working very long hours. I was running a PR agency. And because of that, you know, I put a lot of pressure on myself. I put a lot of pressure on my own expectations. And then, you know, I didn't exercise. I put on a lot of weight. And, you know, so that was my life then. But all that has changed when the bump came along.
You
Yeah.
you loved the work more than you loved yourself, and you
Then
put
I
yourself
loved the
at the
work then.
then, right, then. And
Yeah.
now you and sometimes it's a calling, not that it's a welcome calling. I wish it's something else, but you know, it's more often than not, you know, this actually changed. So what is the biggest challenge that you face in your cancer fighting journey, apart from it is the peak of COVID, you know?
I think the biggest journey then was the fear of the unknown. Because even though there's a lot of materials on cancer and all that, there's a lot of unknowns. You know, there's, for example, unknown on food. I mean, everyone was giving me dietary advice on what to eat, what not to eat, right down
Yes.
to the taxi drivers that I meet.
Yes. Yes.
They were giving me advice. So in the end, you know, it's just unknown. So I
Yes.
told myself that I'm not going to listen to all this
Yes.
so-called good advice from everyone. I'm just going to listen to the doctor, the people that I trust, and stick to it. So it's really unknowns. But then it's just taking one unknown at one time and living it.
So thank you for the advice, you know, thank you for the love. I would receive them, but then, you know, segregate them and live, you know, the way it is. I like what you said earlier, is that you want to work with your doctors, trust your doctors, you know. I think it's so important, especially for you that you have, you know, 2 years battling this with your doctors. Tell us, you know, your relationship with your doctors, you know, what would you trust them with? Your dog, your prized possessions, you know, what is that relationship like, you know, with your doctors? I think it's very important. A lot of people see doctor, but they don't really know what the doctor is saying, and then they come back, it's like, is it true? Is that doctor trying to do another test on me and things like that, you know? But I honestly think having that trust in your doctor is a really important start for recovery. You know, tell us, what's your relationship with your doctor? Has it changed, you know, after now, you know, all these 2 years?
Okay, I was diagnosed at National Cancer Center, SGH. So it was a team of doctor, but there was a lead doctor that was guiding me throughout. And it was quite nice because every time when my husband and I goes for the checkup, we'll be talking. And there were even instances where we'll be talking about nothing medical. They'll be telling us about his wife and all that kind of thing. So it's a rapport that you build with the doctor. And that helped along the way. And that really helped, not just with the doctor. And there's also one thing that I asked the doctor when I was first diagnosed, was to ask that there's a lot of materials out on the internet about cancer and everything. So which are the credible sources I should read? I wouldn't want to read everything that's there because there's conflicting news. So that helped as well.
Yeah, there's this saying where don't mistaken your Google search as my medical cert, my medical qualification. And is this true? You Google something and then there's so much, and then after you read, which one do you quantify as reliable source? Did you get yourself working into a frenzy for nothing? Or this is something that you would take note? And sometimes while it, during the session with the doctor, confer with it and things like that, did you go and join a support group?
Yes, I did. During that period when I was going through treatment, there were a lot of unknowns. I didn't know what I didn't know. So I joined a lot of support group. I joined whatever associations there were to learn from talks. I attended talks religiously. I attended the support group religiously. I went for counseling as well because I felt I needed it. And even though I was a career woman with X years of experience, that didn't help at all because cancer is really unknown. So with the support group and talking to survivors, and that made a difference in my life.
It's such a very, sorry to say this, but good example in the sense that, first, you are a career woman, you have been around, especially in PR, it's not an easy topic, I mean, I was in advertising before, so I know exactly what it can instill and things like that. And even then, you actually ask for help. You join groups that could provide you, answers, maybe not the real answer of the answers, but then people who can show you it is a journey that you are not alone. You have help, and I think asking for help is a good start. That you get that chance to know that there are people who have done it before, they've recovered, they still live a meaningful life, and kudos to you. I think that's a very great first step. So congratulations. I heard that you actually have been working on meaningful project post cancer. Could you share that with us a little bit more?
Okay. During my treatment process, I signed up with the Singapore Cancer Society, the rehab program. The lymphodemus therapist was telling me that water sports is actually very good for breast cancer survivor because the water is gentle on the joints and it helps with blood circulation and everything. So that clicked because I love water sports. I'm an aqua aerobics instructor. And I love, and a patient as well. So that clicked, and I actually started teaching some ladies, breast cancer survivors, aqua aerobics. So I taught them how to move in the water, how to use water to exercise, how to use the water as a gym to help them, with the movement and all that. So that's very useful.
I know a lot of people with breast cancer treatment and surgery, they ended up having what they call the elephant hand, where it becomes difficult to move. There's retention, water to retention, and things like that. Did you experience that, or the what aqua aerobics actually helped?
I experienced that because of the surgery and all. My arms was a bit stiffer, but with water, I think that helped because you do a lot of movements in the water, and that helped as well.
Yes, water is actually very powerful. I've seen people who are wheelchair bound, they literally have a standing vertical position when they're in water because of the zero gravity and things like that. So that's wonderful. Do you intend to do this for long? This aqua aerobics, this working with women with cancer?
Yeah, why not? It's actually very rewarding. Right now I'm actually teaching as well. So I do teach to general public. I do teach to groups of elderly as well. I do teach to, anyone who's open.
From one volunteer to another who is, and I've started my journey with Singapore Cancer Society as a host for public awareness program since 2008. Welcome to this side of the road. And it's great to see someone who's putting a passion into that. I call this my national service to Singapore. And there's no ORD, to this until somebody takes over the reign for this, and so I think this is wonderful. So welcome, to the club, and Let's see. Now, what advice would you share with ladies or fellow breast cancer survivors, who are tuning in today? Or even people who maybe I have, maybe I don't. What should I do? What would be the advice you would give to them?
I think for me, the advice is love yourself more. Because, women as a whole are very sacrificial animals. They will always care for their family. They will always care for their children. They will always care for everyone. And even as career woman, you always care for everyone else in your office except yourself. So I think women need to love themselves more, take care of their body more, and make sure they feed their body with the right stuff. So it's really love yourself more.
You are what you eat, and our body is our temple. It does shows. I was just reading about something. Somebody was talking about glowing skin, and she says, all I did was drinking a green smoothie in the morning to fulfill what I need in the day. And a lot of us would think, oh, I'm too busy, I don't do this, but then if we don't love ourselves, who will? Right? So thank you so much. Anything else that's upcoming projects, would you like to share when you do the aqua, is there an association that you belong to that people could join you? Am I allowed to ask this?
This is promotion. Interestingly, next Friday night, I'm actually giving a session to breast cancer survivors, a trial, deep water aqua trial at OCBC Aquatic Center. So it's full now, and there's actually a waiting list.
Okay.
But having said that, I do teach at OCBC Aquatic Center, Singapore Sports Hub.
So anybody who's interested, they should check it out with the Sports Hub.
Yep.
Okay, thank you. And this is not for promotional purposes, but really for health purposes, for people who want to seek help, all right? So we need to do this disclaimer in this manner. Now we're going to come to the next session on Q&A. So let me bring back the doctors and also polling to the scene. You can see everybody is there. I'm sorry I couldn't be in the studio today because I'm in close contact. So I just want to make sure that it's being responsible because they all moved around to different hospitals. All right. Let's look at the questions that we have.
Thank you, Ivy, for all your volunteering. I just want to say that because it's remarkable the role of volunteers in this journey.
I took the easiest part of the volunteering, just doing this either on stage or with that, a lot of the volunteers who put in those hours, it's amazing, especially when we see during the appreciation lunch and things like that, So Singapore is really a country of love, and especially with cancer education, we triumph a lot of developed countries in many ways, and how it's taken, in such broad spectrum. I'm very, very proud. I've been to countries like Australia and New Zealand. They are very, very different, and despite whatever it is, so here is a very collective effort to educate the public, and the help is so readily available. We should be very proud, and I'm very proud being a Singaporean. When I share those, they ask me to actually tell them what we do in Singapore instead of, so that they could learn from us. So thank you, doctors, for being there. Thank you, polling, who giving back, to the community. So the first question I have is this, 3D mammogram. All right. How regular should, what's the difference between a regular mammogram versus a 3D mammogram, any doctors are going to take this question?
So maybe I'll just start. So basically, a regular mammogram is basically for those of listeners who have not done it before. The breast will be actually compressed between two breast plates, and it'll be done in two different angles. So that would be what we call a two-view mammogram, which we do it in Singapore. But you can almost imagine that would be just a 2D kind of thing, all right? Even though we do it in two views, but certainly it's just two views. But if when we do a digital tomosynthesis or a 3D mammogram, basically what they do, what the mammogram machine do is that it takes a slice of the breast at regular intervals, and then using computers, we have a lot of good stuff in the computers that can actually reconstruct the whole breast. So actually, instead of seeing a 2D image of the breast, we actually see a 3D image. So you can actually see the actual breast, and thus it makes the detection, especially of very small tumors, easier, especially in patients with very dense breasts, right? So that's we usually don't start off with a 3D mammogram because obviously the radiation will be much more because the machine is taking an X-ray at very small intervals, so the exposure is much more. But it's certainly useful in the case when the breast is very dense and the radiologist is concerned about a certain area, or if the patient, of course, is perhaps at high risk or a very young patient. So certainly not for everyone, but certainly the doctors will, of course, recommend it to patients who need even more in-depth study.
Okay. It sounds like a 2D X-rays or mammogram plus ultrasound for this 3D mammogram.
Ultrasound is different. So ultrasound is using ultrasound waves. So there's in the sense that it is good because there's no radiation. So and it's not painful. For I'm sure those who have gone through mammogram, usually my patients will come in complaining of pain. And of course the joke that we have is mammogram machines is invented by men. But
Is it true?
I don't know. I just repeat the joke, but yeah. But anyway, ultrasound. So on the other hand, ultrasound, no compression of the breast, so not painful, no radiation. So one don't have to worry about radiation exposure.
I see.
The problem with ultrasound is that it is not so specific. So it
I see.
picked up a lot of little shadows in the breast, and then the problem is, of course, as doctors, once you see something, you're worried that you're missing, and then you may then lead on to more invasive procedures. So that is an ultrasound. It's not entirely useless. So it'll be useful for patients who have a mammogram first, but perhaps the breast is very dense, or if there is a little shadow which we want to have adjuvant or adjunct to look at it, then ultrasound will be very useful.
Thank you. Dr. Joanne. So,
Yeah,
yes.
Maybe I'll just, I think the clear message here is that for the average population risk individual, just go for your mammogram. The second kind of adjunct or the what else is needed, it's kind of almost a second step, depending on other factors that the doctors might recommend you. But I think one of the things I feel quite sad about when I'm in clinic is I ask women, who come in for other reasons, right? When's your last mammogram? And they go, no, doctor, very good. I've done my mammogram. Then you ask them, when was your last one? Then they'll say things like 8 years ago, So I think it's important that we emphasize it's not just going for your one-off mammogram, okay? It's going for your regular mammogram screening, depending on your age band and your other risk factors, whether it's yearly or every 2 years, it's the regular part that's important, not the one-off, okay? So I think the other finer points and other details about what type and what other adjuncts we can use to support that, I think comes as a second step. The more important is, are people going for their mammograms? If we can reach that first step and do it well, I think we will definitely be picking up many more women in the earlier stages, and that's what we really want. If we can get the stage 3, stage 4 numbers down to under 10%, we can all say we've done a good job. And I think it's a collective effort from everything from volunteers, Cancer Society, to the doctors and everyone else. Yeah. So I would say that would be more important than the final point about what type of imaging.
Yeah, but can I also add?
Yes.
So I think the what we need to remember is mammogram can help pick up like stage 0 cancer before they form a lump, before you can feel it, before you can see it on ultrasound. So that's why mammograms are important. So there are different screening modalities. Talk to your doctors about why we choose certain images versus the others. But as a general population, mammogram helps because it picks up the cancer before you can even feel it. Yeah.
So the thing is this, mammogram is your first step. It's better to have a mammogram, and mammogram is reliable. And in the event that they cannot see what they wanted to see, or they don't think they were seeing what they can see properly, then there will be other tests that's being introduced. But please do go for your mammogram. Now, just a refresher, before 50, every year. After 50, every 2 years, correct? Today I passed. Okay, quick question is that I didn't hear a lot today about, calcify. A lot of people, they go for mammogram, then the doctor says I need to do ultrasound, and they realize, oh, it's calcium. So is calcium something that they should be worried about? Would that eventually develop into breast cancer?
Maybe I'll take that again.
Yes.
So basically, calcification in the breast is super common. When our body actually regenerates, our body cells actually dies, and so on and so forth. And as we grow older, where there is cell death, actually the body may have put calcium where the cell death is. All right. So basically, the bottom line is that as we grow older, we will actually see calcification not only in the breast but in many other parts of our organs. It's just that the breast we do X-ray, and so we see it more. So that's the first thing. So calcification is very common. It increases with age. Now, calcium, as we all know, is found in our bone to make the bone strong. It's also actually found in our blood for muscle movement. And so calcium is innocent, right? So the calcium in the breast will not cause breast cancer. So the only thing is this. Now, if a lady has breast cancer, and the breast cancer, because of the fast-growing nature of it, the center part of that cancer may die off, and then because of the cell death, again calcification may occur within the cancer, and so maybe about 10% of calcification, especially if it's very, very small, what we call microcalcification, that may represent a cancer. So it's important to reemphasize, it is the cancer that starts first and the calcium comes in later, rather than the calcium start first and then cause the cancer. So of course, the radiologists, the X-ray specialists, they are trained to look at the pattern of the calcification and then determine whether this is good and bad. And of course, reemphasize what Dr. Jessie already mentioned. Stage 0 breast cancer usually presents with calcium, and that can only be seen on mammogram, and that's also that is the reason why we have to do the mammogram first.
Mammogram, is the radiation high? Is there risk? What are the people that you wouldn't suggest them doing a mammogram instead?
So the risk is not high. It's about 300 millisieverts. So if apparently as we walk around, we will get about 3,000, if I'm not wrong, 3,000 millisieverts per year. And so this 400 millisieverts, if you do it, if you're doing it on an annual basis, you're actually just getting a very, very small dose. So that's the first off, that it is safe because the dosage is very small.
Okay.
Your second question is there anyone that you wouldn't do it in?
Yeah.
So
Thank you.
I guess the only thing is the BRCA1, BRCA2 group. So I would say that theoretically, if anyone had a genetic predisposition in the BRCA1, BRCA2 groups, carriers, there's the theoretical risk that obviously exposure to radiation may increase your risk. And because we're starting the imaging at a much earlier ages, starting in the early 30s and all that, then you're getting the dose, accumulating the dose over a much longer period of time. There is a recommendation that these patients, especially in the younger ages, when they're 50, they switch back to mammogram, but in the earlier ages, whether or not an MRI breast would be preferred. And in the US, it's routinely MRI breast is being ordered. Here, it's kind of Some patients will take that up. Some patients may have other concerns, such as cost concerns and the rest of it, and that's weighed against using mammogram. But that's again another discussion that you have with your doctors and decide accordingly. But certainly in that group of patients, MRI breast is an alternative, it's an option. Yeah.
So if sorry, Dr. Jessie?
Sorry, I just like to put into like practical terms in terms of
Yes.
radiation risk. The radiation of a mammogram is the same as if you take a flight from Singapore to Tokyo.
Okay.
That's the amount of radiation you get, so that's very
Okay.
little.
So if you think you will go to Tokyo, then I think the mammogram on a yearly basis is not an issue.
Precisely.
No, it's really perspective. Thank you so much for that perspective, because a lot of people will just go, oh my God, So coming back to that question from Dr. Joanne, is that, so I'm not sure, okay? And usually we scan for genetics was because we have first line relatives that has that, right? Correct? Then that's where we started scanning, with for the BRCA. Now, in the event that I don't know, because I just and there are people who really don't know, and they are in their 20s, 30s, they will go for their mammogram, and they continue to go for their yearly mammogram. And would you say that checking for your BRCA would actually be important? Now, how does that work in terms of that?
So I think if let's say, for example, there's a family history, or in yourself, you were very young when you had your breast cancer, you should go for your genetic testing first, because information is important to then help yourself, but also help your doctors recommend what's appropriate for you. If let's say you have a very strong family history of breast and ovarian cancer, and you say, okay, I'm worried that I might have what Angelina Jolie has, but I don't want to find out the genetics, and then I go for my x-rays every year. You might not need it, that's the danger of it, right? You might actually not carry the genetic change, or there's no genetic change in your family at all to even begin with. And then you're going for unnecessary testing, exposing you to unnecessary radiation, exposing you to other things. So these days, especially because the cost of genetic testing has come down by quite a lot, we don't really recommend people take the high risk recommendations without the genetic testing beforehand, because then you might actually be exposing yourself to unnecessary tests, unnecessary investigations and all of that. So definitely, if you think you have a risk factor, have a discussion, have the testing done. After the testing, the results are out, and then you can decide what you want to do. So I give two analogies that I use very often in the clinic, and patients actually like it. The first is, you wouldn't go to an unknown territory or even for a holiday without some planning. You want some information before you embark. So this is nothing different. It's about having the best information so that you can then map it out for yourself what you need or what you need to do. The other analogy I like to give patients who think genetic testing is a very difficult concept is, I always ask them, and I use this very often in the clinic, so maybe Pauline might even remember. So like, if you are in a very dark road, in a dark village, no street lamps, nothing, and a car comes and pick you up and no headlights, would you get in the car? Will you get into the taxi? And all the patients will say, no, we won't get in a taxi. And I say, why? No, we cannot see the road ahead. So then I say, so what you want the person to do? You want them to turn on your street lights. So genetic test, either the street lights or the headlights of the car. So genetic testing is really nothing more complicated than that. It's simply just turning on the headlights of your car so that you can see, is there a bump ahead? If there's a bump ahead, we can take this path. We take a different path. And that different path might mean earlier surveillance, earlier intervention. And in some other cases, in colorectal surgery, for example, it's more colorectal cancer prevention. It's more early onset colonoscopies, and we completely can reduce that risk of colon cancer in that group of patients as well. So it's really just turning on headlights, nothing more complicated. We're not trying to do anything too difficult here.
So someone wants to say something? No? Okay. The other question I have is this: turning on the headlights. Frankly, I hate to be in the dark. I like to know what it is. But there's one word I needed to ask this question is this: in the event after testing genetically is positive, does that affect their insurance?
So at this point in time, there is a moratorium that's signed by the insurance companies and all. It should not affect anyone who's going for what we call predictive genetic testing, meaning that if you are found to have a genetic change and you want your family members to go for it, they're not allowed to ask for the genetic information in terms of determining that. So this is a moratorium that's been passed. It is something that is being enforced, but of course, there's still a lot of people who are not familiar with it because it's something that's just happened. And so if there's ever any concerns or any issues, it's something for them to, if they run into trouble, at least in our case, we've been helping patients sometimes, because even the insurance agents themselves need to be educated about it. So sometimes we end up educating them and saying, this is not what you should be asking for. You shouldn't be asking for these things. So there's a period of transition, as with many things, and I think over time it become more and more clear. And I think the main thing is do what's medically necessary. Not everybody needs genetic testing as well, and so those where it's medically indicated that they should have it because it will help in terms of their care. I think if they run into any issues, just check in with your doctors, and we will help clarify that if we can for you.
Thank you.
It's an evolving space as well.
Okay, evolving space. Everything is evolving. And quick question. This is the other question we have here is, during breast cancer treatment, can they use TCM to complement the treatment? Some doctors, according to patients, is that they should stop drinking cow's milk. They shouldn't use Chinese tonic like ginseng. I know this is a question that they constantly ask. Let me pave the stage first. Ladies and gentlemen, if you start your chemo, focus on the chemo. Don't try to bring all medicines, whether it's TCM, Tongkat Ali, or whatever medication that you have, and complicate things, because you want to know which one is giving you the reaction. All right. But coming back to it, to the doctors, is this: when they are actually receiving cancer treatment, chemotherapy, etc., what can they do and what can they not do or shouldn't do in order to help that process?
I'll start with that because I'm a medical oncologist, and then maybe everyone else can chime in, especially from Poling's perspective as a patient as well. But I would say that everyone should just recognize that TCM is also a drug, whether it's TCM or the drugs that your so-called Western trained doctors prescribe. They're all drugs, right? They all need to be cleared from your system. They all rely on the same organs that you have to clear, namely your liver and your kidney most of the time. So it's really all about being upfront with both sets of doctors, that if you happen to see your oncologist but also see a Chinese physician, is being very upfront and transparent to both groups to say, okay, these are all the things I'm taking. What do you think about that? Because the worry we have is that you overburden the organs that are helping you clear your medicines and all that, and then you run into problems with toxicity from either one of those things. But in general, I'm not one that tells my patients they can't have TCM. In general, my practice has always been, you just let me know what you're having. We let your Chinese physician know what they're having. We continue to monitor your things. And then also, if let's say they're not on treatment, they decided to go just only for TCM, I've also asked the patients to be very clear that they assess the TCM the way that they would assess chemotherapy. Meaning that, if they're not on any treatment, is your cancer responding to the TCM? Be equally, because some patients are actually very, very fearful of like the chemotherapy, but all accepting of what they're being told in regards to the TCM. So I think you should be equally, so kind of like the same scrutiny that you give your TCM, your chemo you give to the TCM as well. So these are some of the various things. So I think the first thing is to say is just to be upfront with your doctors that what you want. Sometimes the doctors will also say, okay, you're having a lot of side effects from your chemo, you have a lot of neuropathy, it's time to take a break from your chemo. Now's a good time for you if you want to do your TCM. You can go and do that, and we often do that collaboratively. At NCCS, we do have some staff who are TCM trained, and they do provide advice. And we sometimes refer them directly to those staff as well who are TCM trained. I'm not sure if anyone else has anything else to add to this.
Pauline, did you use TCM?
No, I didn't, because I wasn't seeing any TCM doctor, so I didn't. So it was too complicated then, so I just trusted my own doctor.
You just want to focus on the treatment that they have prescribed for you, and then you want to see what's the result for that before you make other decisions. Okay.
Yep.
So there's a huge difference between 食疗, which means food therapy, versus TCM as in Chinese medicine. All right. So if you're looking into eating properly or gaining your energy for chemotherapy, that's very different from going to TCM where they give you different types of medication to 补气 or whatsoever. So you need to understand the difference, the distinctive difference between these two. Not that you can't, but you need to understand that so that it doesn't compromise, because some of the Chinese herb that you use, like ginseng and all these things, they also actually affects the hormones, especially when the breast cancer could be a hormone doing hormone treatments, etc. All right. Two last questions. There's so many questions, to be honest. It's really hard to pick one. And then, ladies and gentlemen, if you did your questions did not be answered, we will pick the most commonly asked ones, and put them on the Facebook page. So how do they actually get the chemo drug that is not hair falling? Is this a possibility for treatment?
Okay, okay, sorry. It's a very important question, and it's certainly hair loss is very important to patients. Okay, so I think very valid question. Okay.
Yes.
I will just say that there is an armamentarium of drugs that can be useful. So, for example, if a patient is in stage 4 breast cancer, very often we don't even start with chemotherapy, especially if it's hormone positive. It may be appropriate that they just have anti-hormonal treatment as the first line. So I think certainly discuss with your clinicians what's important to you, especially a lot of patients will tell us, my son's getting married or my grandson's getting married, I want to delay. So these are all things you should raise, okay, with your doctors and tell them what's important to you at that point of your life so that they can take that into consideration. Now, in the adjuvant and the neoadjuvant setting, there are certain regimens where there's been evidence that it's actually much more effective, and that can lead to hair loss. The important thing is that hair regrows and that hair comes back, okay? And if it's medically important that it will improve your survival because you had that regimen for whatever reason it is that your doctors have just told you about it, then I really think it's a matter of just telling yourself, reassuring yourself that the hair comes back. Bald can be very, very beautiful. I have many patients show me beautiful pictures of themselves in the period where they don't have hair. For some women who there's alternatives like wigs as well that are very well done these days, and I think both SCS as well as Breast Cancer Foundation and others have contacts if you do need that those contacts. So I think there are many alternatives. So I think the most important thing is what's good for your health and what's good to keep you well as the main thing. And if you are worried about hair loss, just tell your doctors. They can tell you about the strategies about how to handle some of these things. I'm not sure whether I would love to hear Pauline. Did you have to go through chemotherapy and was that a concern for you?
The hair loss bit was just vanity. Yeah, but my focus was really on getting well. So, but the good thing about hair loss is that when it starts growing back, it's very soft and nice. And then there's less gray hair now, so it's fine.
So it's the upside, okay? Between your boobies, your breast, your hair, your life, and what's important to you, you have to make a priority. You have to make a priority list, which one is more important, and then you seek treatment from there. I'm going to ask the last question, although there's so many of them.
The hair loss thing,
Yes.
actually NCs have a scalp cooling therapy.
Yes.
Which they do give during chemo and can help mitigate some of the hair loss. So some patients actually find that useful.
But it can be quite tough because it's very cold. We have that NCC as well, but we do find some patients tell us that that's actually quite cold and quite difficult as well to get through. So the thing is, it comes back for those on adjuvant and neoadjuvant. It comes back and sometimes comes back nicer. So I think, yeah.
Well, like I said, develop the style, own it. And quick question here is this. Mother is diagnosed with stage 4 cancer at the age of 69. The daughter is 39 this year. Is this a recommendation to do genetic tests?
Yeah.
And is this subsidized?
So I think the two things. One, the age alone is an indication, the 39, and the fact that there's a family history is certainly an indication. The consultation at across all the clusters in the health system, there's genetic services in all three clusters. Is subsidized. The consult is subsidized. The testing right now is an out-of-pocket expense, but there will be a program which is happening soon where we will be able to provide a little bit of help with the testing costs. But certainly right now, go see your doctors and they'll take it from there. We have all the time different programs that come in, some for financially needy patients who need the testing, some for if you need it for your treatment decisions. There's also programs where the test is subsidized. So I don't want to go into it too much because it's variable depending on the situation, but just go and get your first visit into any of the three clusters for wanting to do testing, and then take it from there. The doctors will take it from there. Yeah.
Thank you. So one last round from all the doctors, your parting words to all the participants today, and before you start with yours, Dr. Patrick, is that at what age, given that the trend of breast cancer is getting younger and younger, at what age do you think they should start doing their screening? And what is your parting words for today's session?
Okay, so I think for breast self-examination, we should teach the younger to start at, well, anytime. A lot of patients do tell me that they don't do breast self-examination because they don't know what they're looking out for. And my advice to them is perhaps just do it, just keep doing it. And after a while, you will know what your normal feels like. And then if there's something that is out of sync, you would recognize it. So I think for breast self-examination, start as and when. And then of course for mammogram, as what we have said, start at 40 annually, but certainly 50 is mandatory, right? That it's very important for us to do that, and of course to seek. So my last thoughts is, I'm still seeing many patients who actually feels a lump, and they hope that it will go away. I mean, it's human nature, right? When we feel something, we hope that it will go away, and so I'm still having quite a number of patients where they keep the lump. They don't, especially for some of the older folks, they don't tell their family members, and they keep it for a few months to years, and thus my parting shot will be, please, if you feel anything, any symptom in the breast, go and see a doctor. It may be nothing, but it's better to be sure. Yeah.
Thank you. Dr. Joy?
I guess it would be knowledge plus action is power, and that you're not alone, and that there's a wide team that is here to look after you, both from the community as well as from the healthcare sector. And sometimes patients feel lost. They don't know what's the first step to take, what to do. And I think that's partly our faults as well, from the healthcare side, as well as maybe we're not doing enough. And certainly such webinars is helpful. But I think for anyone who's listening and is not sure what to do, ask your neighbor or ask your sister, ask someone around you first, and then if not, just write in. We all have hotlines that are more than happy to address some of these questions. Yeah.
Or approach the Singapore Cancer Society, and then there are also medical counselors that's available in the hospital. If you said that I need to speak to somebody because I'm lost for that thing, lost for choice, there's too many, I don't know what to do next, this is actually readily available for you. Dr. Jessie, parting words to our community.
Parting words, I think early detection, early treatment is good, and I think don't be afraid to talk to your doctors because there are many options available. I always tell my patients that no matter what you choose, our aim is to make you look the same, wearing the same clothes, and nobody can tell, and the help is always available. We are a community to support you, so don't be afraid to seek help.
Thank you. Pauline, to the women out there, all their family members, what do you want to say to them?
Love yourself more.
Thank you. That is such a powerful thing. Love yourself more. I've seen so many women my children, the program, the car needs servicing, the aircon needs servicing, anything else is more important. But you know what? The most important and most expensive asset that you have is yourself and your health. All right. So ignorance is not bliss. And the knowledge is power, and help is readily available. And please, do your regular screening. I have information here. For more information on Singapore Cancer Society's $25 mammogram funding assistance, kindly visit the Singapore Cancer Society website. And also, you can check on the funding assistance over there. And let me do the usual finishing of today's sessions. That's strange. I'm having a conflicting screen at the moment. Just a moment, please. Yes. All right. Now, a few things. We acknowledge that October is Breast Cancer Awareness Month. So the few initiatives we mentioned earlier, you can join, to show your support and help raise awareness is for breast cancer is Singapore Cancer Society, $25 mammogram funding assistance. And to qualify for this funding assistance, appointment must be made at participating breast cancer screening center by the 15th of November 2022, and the mammogram screening needs to be done by the end of 2022. All right, so do make the appointment. And the Singapore Cancer Society clinic is actually at the Bishan. So over there also they provide mammogram screening at no charge at all year round for women with valid orange or blue CHAS card. Any questions that you have, visit the Singapore Cancer Society website or call 1-800-727-3333. BCAM is also a fundraising campaign for giving.sg. So this year, they are partnering with the National Volunteer and Philanthropy Center, NVPC, for a fundraising campaign on giving.sg, where you can support many breast cancer related causes. Visit www.giving.sg. Stroke Breast Cancer Awareness 2022 to read more about the various causes and how your generous donation will help lessen the impact of cancer in our community. We would like to thank our speakers, Dr. Chant, Dr. Nyao, Dr. Hu, and Po Ling, for spending your time with us, sharing your knowledge, your experience with us. We hope, all our participants have learned a few ways that you can take action to reduce the risk of breast cancer. Once again, we'd like to thank our sponsors, MSD and AstraZeneca, and partners of Breast Cancer Foundation, National University Cancer Institute of Singapore, Screen for Life, Sing Health, and Tan Tock Seng Hospital for their support. And lastly, we would like to thank each and every one of you for your participation in this webinar. We've come to the end of today's Singapore Cancer Society 2022 Breast Cancer webinar. Thank you again for joining us this morning. Help us complete the feedback form, which you will see the QR code now. Your feedback is very important to us. With your feedback, we can do better. For the frequently asked questions or the most commonly asked questions, please do look back into the Singapore Cancer Society Facebook page. We will put the answer there, and also the Singapore Cancer Society webpage. All right. And for more Singapore Cancer Society screening initiatives and other programs, again, please visit www.singaporecancersociety.org.sg or call 1-800-727-3333. Early detection does save lives. So thank you again for all of you for joining us this Saturday. Stay healthy and love yourself more. My name is Ivy Lim. Have a great Saturday. Thank you.